So how does acute pain become chronic pain? Well, really, we're finding that it's reliant on the function of the brain. And a lot of the function of the brain is really about storing memories and learning. And so learning and memory is a huge part of what makes acute pain different than chronic pain. So we're now of the realization that pain is not an automatic response. It's not a sensory response. It's really a learned response. And as a learned response, it involves memory, but specifically in people with chronic pain, it involves long-term memory formation. And so if you look at long-term memory formation, if you look at some of the research in terms of long-term memory, we really realize that it's broken down into two types of memory. There's implicit memory and there's explicit memory. So if we look at the chart on the left, we start to see implicit memory are those unconscious memories that occur, whereas explicit are those conscious memories that we can retrieve. If we take a look to the right, that chart, it's important because it breaks down explicit and implicit memories for us. And it tells us like the explicit memory is really about facts and events. And it tells what areas of the brain are active. But you'll see that a majority of the areas of the brain are active really are that implicit memory. The amygdala, the neocortex, the striatum, these are all areas that are really light up when people have pain. And so you'll see that it's really about priming our pain systems. It's about the procedures and habits that are developed. And it's really about associative and non-associative learning. And these are big factors. And this is the focus of a lot of the research we're doing, is the role that associative learning and non-associative learning has in developing these pain responses. So if we start to look at implicit versus explicit learning of pain, we realize that most research is showing that only 10% of our explicit learning of pain revolves around explicit memory factors. 90% or so of our learning that we do about pain occurs at a subconscious level. So if we start to learn how do we learn about these pains, really we're realizing that it's really probably an associative learning process that occurs when we start to condition our brain and we start to develop these learned memories. So if you look and remember back to your high school days, you'll start to see from your psychology class this concept of Pavlovian conditioning. And really, if you look at Pavlovian conditioning, you look at it as there's this conditioned stimulus, which is food in Pavlov's studies, and he rang a bell at the same time. So that was our unconditioned stimulus. You guys remember that study, right? So he rang a bell and he gave the dog food at the same time. And after a while, they got paired together. And so what happened is pretty soon they can still get the same conditioned response, which in the dog's case was saliva, without food. So pretty soon the ringing a bell can produce saliva. We're thinking that that same type of process occurs when someone has pain. So when someone's injured, they have nociceptive input that goes up to the brain. But remember at the beginning of this talk, I said, well, it's also that we have to realize that there's other things that are conditioned at the same time. So there's sights, there's sounds, there's smells. All these things go to the brain and they are processed at the same time. They get conditioned and paired together. And pretty soon, we have a pain response with the two of them being conditioned together. In our patients with chronic pain, pretty soon that we do not have to have the food anymore. We do not have the injury anymore before our patients have pain. We can have just the conditioned stimulus. We can have the contextual cues, the sights, the sounds, and smells that become triggers that can help change our pain responses. And so that's the process of associative learning that's occurring in our patients. So as we start to take a look at the research, some of the research that my group is doing, we took a look at the effects of conscious memory on pain. So what did we do? We ran a study and we wanted to see what are the effects of short and long-term pain memory on pain perception. And so what we did is we put our group of 60 subjects and we divided it into people who had a past history of significant injury. So they had a trauma to their lower extremity. Now that trauma, how did we define it? We said anybody who had enough of an injury that they had to be on crutches for 2 weeks or they had to have surgery, they were considered someone who had a traumatic injury to their leg. And we compared that to people who had no history of injury to their leg. So we had 2 groups, 30 each in both of those groups. And what did we do? What we did is over the site of injury, or a comparable site in people who had no prior history of injury, what we did is we first put mechanical pain to that area. So what we did is we put maximum amount of pain, as much as they could tolerate, and we measured their responses. The second thing we did is we asked them to remember that pain that they just had, and we measured certain outcome responses. The third thing that we had them do, so the third condition, was we had them remember their past injury. So we had them do a long-term memory of that area that was injured. And for people who had no prior injury, we just had them focus on the temperature of how their leg felt at that time. And what did we measure? Well, we measured a couple things. For the purposes of this talk, we measured pain thresholds, which is really when someone first starts to feel pain. So right after they had their stimulus, whether it's the short-term memory of pain, the actual pain, right afterwards we said, okay, we're going to measure pain and we want you to tell us right when you start to feel it. And we measured that over the anterior talofibular ligament. So that was very consistent for every single person we taught. So what were our findings? Well, it's interesting. If you take a look at the diagram on the top left, you'll see that when we gave someone experimental mechanical pain, the people with a prior injury, they experienced pain a lot quicker. So they experienced pain faster than people who didn't have a prior injury. We looked at people with no prior injury, and we found that it took more of a stimulus before they actually start to experience pain. And so there was a difference in processing we found between people with a prior history of pain and people with no prior history of pain. So people with no prior history of pain, we found that they actually took more pain in that area before they felt it. And that kind of makes sense from a protective mechanism, that if you have no prior experience of pain, you're going to take more because you're threatened, because you want to escape from that pain. But people with a prior injury, we found that they experience pain a lot quicker. And that to us was an indication that people had learned about pain from their past experience. So now what happens is they experience pain a lot quicker as a protective mechanism, so that if they get the same stimulus into that area, what happens is their brain says, I've experienced that before. I better warn myself and I better take protective responses so that I can limit the amount of damage. And so I'm going to lessen my pain threshold so I can warn the rest of my body that something's coming on. And so we found that there was a difference. Now it's interesting. If we asked them to recall their pain after about 5 minutes, what we found is that in people with prior history of injury, their response was actually quite a bit more dramatic than the actual experimental pain. You could see how much that dropped. It dropped 10 kilopascals as opposed to the 3 that we can see experienced with the actual experimental pain. But what about people who've experienced it long term? Can those pains that we've experienced long term in the past still impact our patients? Well, look at the long term memory results. These patients, if you look at them, they experience pain upwards of 5-10 years prior. And you can see that when we ask them to remember their injury and the pain associated with it, look at the same decrease in pain that you can experience from people with prior injury. You can see that it was a similar type of reduction and anticipatory reduction in pain threshold that experienced with the short-term pain memory. So it's evidence that even the long-term memory of pain, those things experienced way in the past, can impact how we process pain. The important thing to realize is that we have long-term pain memories that are formed, and these long-term pain memories can impact how we perceive pain in the future. as we start to look forward to the research and future directions research, we're really starting to target and look at how our brain subconsciously learns about pain. And we are not the first people to start to take a look at this. Really, there's a group of researchers that are doing some great work at subconscious learning and pain, and we're going to start to piggyback off of some of the work that they're doing. Now, Vicki Madden and Daniel Harvey and Jensen, they are all doing great work. Vicki Madden's in South Africa, Daniel Harvey's in Australia, Jensen, I forget where Jensen's at. But all of them have taken a look at subconscious learning. And so how do you study this? Well, the interesting thing that they looked at is they took someone and they gave them some type of pain. Sometimes it was a laser-generated pain, sometimes it was a thermal pain. But what they did is they gave subjects a pain. But while they were experiencing pain, what they did is they gave them a subconscious cue at the same time. Now, what was the subconscious cue? Well, varied from person to person and researcher and study to study. But some of the researchers, what they did is they had them hold on to a rod, and that rod gave vibrations continuously. And each time they felt to experience pain, they changed the vibration in the rod. And so then pretty soon what they did is they kept the vibrations, and they measured pain with the different vibrations, the pain thresholds. And it's interesting that whenever the vibration hit the same vibration that was paired with the patient's pain thresholds decreased, so they became more sensitive to pain. When you ask the patient or the subject, hey, did you notice a difference in the vibration? They said, no, it's the same vibration all the way through. So subconsciously, they were still picking up the changes in vibration. So what are the clinical implications as we start to go through? Really, one of the major implications is realizing that these long-term memories from research in PTSD, we're finding that really long-term memories take about 30 days to form. And so if we can start to intervene in our patients before 30 days, we can realize that we can keep them from becoming long-term memories. So really, we have a 30-day window to reshape our patients' responses. The problem is we don't often see people in our first 30 days. So as physical therapists, we really should be advocating to get patients earlier. But if we don't get them early, what do we have to do? We have to look to realize that when we're looking at people, we can't be targeting and looking to say, okay, what's the injured tissue? A lot of times what we need to be looking at is, well, what are the things that are associated with it? What have become triggers? So it's about asking patients about, how were you injured? Where were you injured? What are the sights and sounds and smells you remember? What are the emotions that you were going through at that time? Was there anything significant? And starting to figure out what were the things that were paired together associatively and now can be a driver of some of these symptoms that we're having. You can say, well, someone just bent forward. Well, then sometimes it could be things like proprioception or the hormones that were present at the time of injury too that can drive and trigger this. But also realize that one of the main stimulus for forming these long-term memories we're thinking is fear. So a lot of times you want to target and you want to look to say, okay, was there any type of fear associated with someone, any type of thing where the brain really needed to form a long-term memory to warn itself in the future of a need to protect. So once we've figured out what these triggers are, we have to develop new memories that focus on rechanging. We're pulling out the pain, reshaping it, and putting it back in so that when it's recalled again in the future, it's not a painful stimulus. And the final thing to realize is we don't have to reinvent the wheel. People have a tendency to say, well, I have to completely change the way I treat patients then. No, that is really a false way of looking at things, because we now realize that your biggest advantage is what you do already. The difference is that you have to realize that we're not trying to change a tissue response anymore. We're trying to change a behavioral response that's formed in memory. So what your target should really be not so much about offloading tissue. It should be changing the fear and negative consequences that have been associated with whatever movement occurs. And in order to do that, you can do a lot of things that you already do. But that was just a brief glimpse into what we're looking at in research and some of the things we're looking to in the future, and how it's helping to shape how we look at pain and how we can become pain experts in the future.